ఎర్రగా వచ్చింది
వస్తుంది మేడం వస్తుంది చెప్పండి
వచ్చిందా ఇది ఒకసారి స్టాప్ చేయరా మళ్ళీ చేస్తానండి కాపీ
స్టాప్ చేస్తే మళ్ళీ ప్రాబ్లం అవుతుంది.
స్టాప్ చేయకండి.
ఓకే
చేయండి ఏం కాదు, మినిమైజ్ చేసి చేసేసుకోండి. ఏమైనా స్విచ్ ఏ మేనేజ్మెంట్ పెట్టినవాడా అంత పెద్దది ఇక్కడ మన ఏమంటారు జయలలిత
లోపల
Good morning everyone. Today we are going to deal with the topic of nutrition. Arpita. Today we are going to deal with the topic of nutrition and fluid therapy in surgical patients. So, coming to the introduction, the malnutrition is a very common finding in case of surgical patients. So this is a picture showing a severely malnourished patient with this muscle wasting and there is also fat wasting. There is visible ribs and the wasted abdominal muscles and the wasted muscles of the arm, forearm. So this patient is an example of a severely malnourished patient. So this kind of patients we overcome in case of surgical cases. So malnutrition is common. In case of 30% of the GI gastrointestinal diseases, there is malnutrition, and in case of 60% of the post-operative patients who have to stay for prolonged periods in the hospital, they suffer with malnutrition. So it is frequently unrecognized because unless there is a huge weight loss, as shown in the picture, the acute malnutrition which occurs in case of trauma, sepsis, which occurs in a period of 5 to 7 days is not recognizable as easily in a chronic malnourished patient. So the aim of nutrition support is mainly to identify those individuals who are acutely malnourished in a span of few days and to give supplemental nutrition for these patients. In chronically malnourished patients, the body changes have already occurred, so there will be many physiological changes which I'll be dealing later. So these changes have already occurred in the chronic patients, so they can be given nutrition supplementation by slowly increasing the nutrition. But in case of acutely malnourished patients, the nutrition supplementation should be given in a precise manner in a definite period of time. So it is important to identify these patients who are at risk of going into chronic changes in the physiology. So what are the different physiological changes that occur in the body when we starve? So when we don't take nutrition, so what are the main physiological changes that happen? First, in a short fasting, after 12 hours if we fast, then there will be decrease in the insulin and there will be increase in the glucagon. So the meal which you take in the last 12 hours is absorbed totally in those 12 hours. So after 12 hours in the next 24 to 48 hours, there will be glycogenolysis. In the liver there is glycogen. There are glycogen stores which are up to 200 grams. So in the next 24 to 48 hours, those glycogen stores are broken down and glucose is produced. So some organ systems of the body like brain, WBC, RBC, they depend only on glucose, so they don't take any other nutrient other than glucose. So for that purpose, body has to produce glucose, or it has to be supplemented with glucose. So these glycogen stores are depleted in the next 24 to 48 hours. After that, even if the patient is starving, then comes the role of muscle glycogen. So muscle glycogen is difficult to break down. It consists of up to 500 grams of the glycogen reserve in the body. So this initially is converted to lactate. This lactate is transported to liver. In the liver, this lactate is converted to glucose. So this is the Cori cycle which we read. The Cori cycle consists of the production of lactate in the muscle, the transport of lactate to the liver, and production of glucose in the liver. So this glycogen store is up to 500 grams in the body. Now with further increase in the demand of glucose, then there will be gluconeogenesis. So till now glycogen stores are broken down, so they are the stores of glucose only. But now afterwards, the muscle which is present in the body, muscle is broken down. So that is gluconeogenesis takes place. Production of glucose from other than glucogenic stores. Those are proteins, amino acids, and fat. So the most common in the liver, the amino acids are broken down, like most common glutamine and alanine. Those are broken down to produce glucose. This skeletal muscle is lysed. It is broken down up to 75 grams per day in case of a malnourished patient. But as soon as we supplement an exogenous glucose, this is readily reversed. Then with more prolonged fasting, even after 48 hours of fasting, then there will be gluconeogenesis from the fat stores. Fat is depleted. It is the triglycerides are converted into glycerol and fatty acids. So these fatty acids, they also produce ketones. After 48 to 72 hours, the ketones are produced. Ketones are produced. These ketone bodies are also utilized by the brain cells. So this is called the fat fuel economy, so in which muscle is being spared and fat is used in place of muscle. So this is called the fat fuel economy, which spares up to 55 grams of the protein being broken down. Next, there will be changes like the body metabolic rate decreases, and there will be decrease in the conversion of T4 to active T3. So this is all what I have explained. There will be decrease in the plasma insulin, increased plasma glucagon. There will be hepatic glycogenolysis. Glycogen is broken down to glucose. Protein catabolism in the muscle. Hepatic gluconeogenesis, that is alanine and glutamine in the liver are converted to glucose. Next, lipolysis, mobilization of the fat stores, increased fat oxidation. There will be overall decrease in the protein and carbohydrate oxidation. So that is the fat fuel economy. There will be adaptive ketogenesis. So the body adapts to utilize the ketone bodies as their energy fuel. Next, there will be decrease in the metabolic rate. Normally a human 70 kg individual needs 25 to 30 kilocalories per kg per day, but that is decreased to 15 to 20 kilocalories per kg per day in case of starving, that is fasting patient. Next, coming to the metabolic response to trauma and sepsis. So starvation is a chronic thing, so body has time to adapt to it, but the trauma and sepsis are acute things. So in a very short while, the body has to produce glucose. So what happens in this? There will be increased counter-regulatory hormones, that is adrenaline, noradrenaline, cortisol, glucagon, and growth hormone. There will be increased energy requirements, whereas in starvation there is decreased energy requirements. So here it is up to 40 kilocalories per kg. Increased nitrogen requirements. There will be insulin resistance, which is insulin levels are increased but they cannot act at a cellular level, and glucose intolerance, preferential oxidation of lipids, increased gluconeogenesis and protein catabolism. There will be loss of adaptive ketogenesis. So there we have adaptive ketogenesis. Adaptive ketogenesis is present there, but here there is no adaptive ketogenesis. There will be fluid retention and associated hypoalbuminemia, wherein the albumin levels in blood are decreased. So as soon as we see a patient that we should know whether he is having malnutrition or not. So there are various techniques to evaluate the malnutrition. First one is the laboratory techniques, which includes the measurement of serum albumin. Albumin is a vague indicator of the malnutrition. Its levels are decreased in a starving patient, but it is not a reliable indicator. So values less than 30 grams per liter is considered malnutrition, and there will be defective immune function in case of malnutrition. So the levels of the blood cells in the body can also be measured. And coming to next, body weight and anthropometry. This is a reliable indicator of the malnutrition. Body weight. So if in a malnourished patient, if there is unintentional weight loss of more than 10% in the in the preceding 6 months, unintentional loss of 10% of body weight in the preceding 6 months is considered as weight loss, that is malnutrition. So again, we have to measure the person's weight, and we have to compare it with the ideal weight for that age and for that height. So that is what the BMI, body mass index, which is weight by height in meter square. So normal values are 18.5 to 24.5 kg per meter square. But if it is less than 18.5, so we consider the patient as malnourished patient. And if it is less than 15, if BMI is less than 15, then there will be mortality. So in surgical patients, if it is less than 15, there will be post-operative mortality. So we have to consider the BMI. Next, coming to other measurements like skin fold thickness, mid-upper arm circumference. Then there's a tool called bioelectrical impedance analysis, which measures the intracellular and extracellular fluid volumes. So based on that, we can calculate whether the patient is malnourished or not. Next, coming to clinical findings. So clinical findings, what we have to take a proper history and examination. So how is the food intake in the previous days, and how much energy is he able to produce, and what is his activity level and all. So the WHO the WHO implemented this MUST tool, that is malnutrition universal screening tool. Malnutrition universal screening tool. So here we take into account 3 factors: BMI, weight loss in the last 3 to 6 months, and acute disease effect. So BMI, a score is given 0 if it is more than 20, 1 if it is more than 18.5 to 20, and 2 it is less than 18.5. So next, coming to the weight loss in the last 3 to 6 months. Weight loss in the last 3 to 6 months. If it is less than 5%, there is less than 5% of weight loss, score is 0, 5 to 10% 1, and more than 10% 2. Then acute disease effect. Add a score of 2 if there is any likelihood, if there is any disease in the past, or there is little nutrition intake in the last 5 years. So we add all the values. Overall risk of undernutrition, if the score is 0, it is low, if the score is 1, it is medium, and if it is 2 or more, it is high. So if the score is 0, then we do routine screening every month or every week. And then if it is 1, then there is medium risk of malnutrition. Then we observe the patient, we document the dietary and fluid intake for 3 days, and repeat screening after 6 months. Then if it is more than 2 or more than 2, then we refer the patient to dietitian, implement local policies. Initially food is allowed because the patient is starving in the past days, so we have to initially give food supplementation followed by other supplements. So this is the MUST tool. This is very important. Next, coming to this is the various methods to assess the malnutrition. Next, coming to next, coming to the fluid and electrolytes. So fluid and electrolytes, fluid intake in the body is from both the exogenous and endogenous. Exogenous is the fluid which we take from the food, from the water and all. Endogenous is the fluid which is produced due to the oxidation of the solid foodstuffs which we take. So the total body average daily water balance of an individual is observed as there will be a total urine output of 1500 ml per day, and there will be fecal loss of 400 ml per day, and insensible losses, that is due to from the skin aspect, up to 900 ml per day. And intake from the food, from water from food, it is 1000 ml, and beverages is 200 ml, and water from oxidation is 2. So there will be a balance between the intake and the output. So these both should have balance. If the output is less, then there's a problem with the excretion and all. So if the intake is less, obviously output also will be less. So there should be adequate intake and adequate output. So in coming to the electrolytes, we have the main electrolytes which maintain the osmolality are the sodium, potassium, calcium and magnesium. So the intake of sodium should be up to 50 to 90 millimoles per day, and potassium is 50 millimoles per day, calcium is 5 millimoles per day, and magnesium is 1 millimoles per day. These have to be taken. Next, the various fluids. In case of need, we supplement different types of fluids to the patient, to the surgical patients. So what are the various types of fluids? So this is the Hartmann's solution, which consists of sodium 131 millimoles per liter, potassium 5, calcium 2, chloride 111, and lactate 29 millimoles per liter. So this is the only fluid which contains lactate. Next, normal saline, which is 0.9% sodium chloride, which contains 154 millimoles of sodium and 154 millimoles of chloride. Next, dextrose saline, which is 4% dextrose in 0.18% saline. So which contains 30 millimoles sodium, 30 millimoles potassium, and the remaining is glucose. Next, gelofusel. These are the colloids. Gelofusel, hemacil and hetastarch, these are the colloids, and first three are the crystalloids. So gelofusel contains 150 sodium, 150 potassium, and there will be gelatin of 4%. And hemacil, which contains 145 millimoles sodium, 5.1 potassium, less than 1 of calcium, and it contains more chloride, 145 millimoles of chloride. Next, it contains polygelin up to 75 grams per liter. Next, hetastarch, which contains hydroxyethyl starch, 6% solution. So these are the various fluids. The most commonly used fluid is the Hartmann solution. Next, when we are infusing the patient with liquids, with fluids, which I described above, so we have to monitor the patient, like whether the fluid intake is sufficient for the patient or not. So what all have to assess? We have to assess the pulse rate, blood pressure, urine output of the patient, and CVP, that is the central venous pressure, if the facilities are present. Then what are the losses which are occurring from the body, like urine output if the patient is having diarrhea, vomiting, any ileus, any GI output fistula. So we put some stomas for the patient, like jejunostomies, ileostomies. So what is the output from the fistula? So that also we have to calculate. And what are the insensible losses, and what are the fluid losses from the drains. And we have to also calculate the electrolyte imbalance, which is caused by the loss of these electrolytes from the different routes. So depending on the site, like if we have a duodenostomy, then we have to calculate the electrolyte deficits based on the composition of electrolytes in that part. So it is different for different sites. So in saliva there is 10 millimoles of potassium, sodium 25 of potassium, chloride 10, and bicarb 30 millimoles. In stomach we have more of chloride because it produces HCl, so 110 millimoles of chloride, and 50 sodium and 15 potassium. In duodenum we have more of sodium. Duodenum, ileum, pancreas and bile, they have 140 millimoles of sodium and 5 millimoles of potassium. And duodenum, ileum and bile have 100 millimoles of chloride, and pancreas has 75 millimoles of chloride. Now there is no bicarb in duodenum. In ileum there is 30 millimoles of bicarb. In pancreas 115 millimoles of bicarb, and bile in bile there is 35 millimoles of bicarb. So these all we need to know, because to calculate the electrolyte deficits if there is fluid loss from the respective organs. Next, nutritional requirements. So we identified that a patient is having malnutrition, so we have to supplement nutrients for the patient. So what are the various nutrients we supply? Mainly contains carbohydrates, proteins, fats, and we also give amounts of vitamins, minerals, trace elements also, because there will be trace element deficiency also in prolonged cases of malnutrition. So we have to feed the patient, but there should be no overfeeding. So overfeeding is the most common cause of all the complications in a we are giving a feeding regime to the patient. So we have to monitor it. All these should be monitored in that patient. So what should we monitor in daily, weekly and fortnightly? So daily we have to monitor weight, fluid balance, full blood counts, urea, electrolytes, blood glucose, electrolytes and volume of urine, and intestinal losses and temperature. So these all we should measure daily. And weekly we have to calculate urine and plasma osmolality, calcium, magnesium, zinc and phosphate, plasma proteins including albumin, liver function tests, thyroid levels, acid-base status and triglycerides. Fortnightly, that is for every 15 days, we have to calculate serum vitamin B12, iron, folate, lactate and trace elements such as zinc, copper and manganese. So we have to calculate all these, because whether the patient is having all the nutrients in an adequate manner. Next, so when we are giving a nutrition supplement, how much energy we have to give it is up to 1300 to 1300 to 1800 kilocalories per day we have to supplement. And carbohydrates, so we give infusions, both glucose and fat mixed, combination of glucose and fat. So because there will be no reactions in the body, so most of the body utilizes only glucose. So in a so up to 2 gram up to 1500 kilocalorie per day of energy can be given in the form of glucose, and up to physiological maximum. So up to the level body needs glucose, that level glucose can be given. And we should avoid hyperglycemia, because it causes glucose intolerance and insulin resistance. Next, coming to fat. So body needs 4 types of fatty acids most commonly, that is 2 saturated and 2 unsaturated. The 2 saturated are the palmitic and stearic acids, and the 2 unsaturated are the oleic and linoleic. So these unsaturated fatty acids, they are obligatory for supplementation, because usually we get those unsaturated fatty acids from the diet, so they have to be supplemented. Next, a liter of emulsion per week should be given. So 1 liter of emulsion per week of fat emulsion should be given to meet these requirements. Then fat, we know that glucose on oxidation gives 4 kilocalories per gram, and fat oxidation gives 9 kilocalories per gram. So we have to calculate usually 70% of glucose with 30% of fat is combined and given as an emulsion. Next, the basal requirements of glucose are 100 to 200 grams per day, whereas the fat requirements are 100 to 200 grams per week. Next, protein requirements. The body needs a nitrogen requirements of 0.1 to 0.15 grams per kg per day. So but in case of hypermetabolic, like in trauma and sepsis, these needs are increased by 0.2 to 0.25 grams per kg per day. So based on that, we have to supplement protein. Next, vitamins, minerals and trace elements. So we have to supplement vitamin B and C because they are useful in wound healing and collagen formation. They act as coenzymes. Then we have to give vitamin B12 in case of intestinal resections. The B12 cannot be absorbed because it gets absorbed only in the terminal ileum. So we have to supplement vitamin B12 and fat soluble vitamins like A, D, E, K. So they have to be supplemented in case of steatorrhea. And trace elements like magnesium, zinc and iron levels also have to be calculated and supplemented. Next, coming to nutrition supports. So what are the various types of artificial nutrition supports we give to surgical patients? So there are various methods of giving nutrition supports. So first one is a nasogastric or duodenal or jejunal tubing. So nasogastric tubing, where the tube is placed from the nose into the stomach, nasojejunal into the jejunum, nasoduodenal into the duodenum. Otherwise, sip feeding. Whole food by mouth we give in the form of sips, that is the sip feeding. Next, we place the tube directly into the stomach from the abdominal wall, that is gastrostomy, and we place the tube from the direct abdominal wall into the jejunum, that is jejunostomy. And these methods of feeding are used only in patients who are able to absorb the food, who are able to absorb the food taken. So in those who cannot absorb the food, like there is bowel resections, massive resections of the bowel, and there is fistulas, intracutaneous fistulas, so we cannot give oral feeding for those patients. So we prefer parenteral nutrition, that is total parenteral nutrition or peripheral parenteral nutrition. So this all will be discussed now. So nutrition supports is required to all patients who there is no or inadequate intake in the past 5 days. So enteral nutrition consists of sip feeding and tube feeding. So sip feeding consists of where the fluid is given in by the way of sips. So we feed the patient with a spoon. So the feed consists of 200 kilocalories of energy, 2 grams of nitrogen, and 200, which consists of a 200 ml of quantity. So this is used as a temporary mode in patients who are able to tolerate the food which is given orally. Next, there will be significant increase in the calorie requirement of the body. Next, coming to tube feeding. Tube feeding we can give as nasogastric, nasoduodenal or nasojejunal tubes. So or gastrostomy or jejunostomy. So this tube feeding, we insert a tube from the nose into the stomach, that is a rice tube which is used commonly, that is nasogastric tube. We give up to 20 to 30 ml of feed per hour initially. Then during the night time, 4 to 5 hours of break is taken for the gastric secretions to occur. Then in the morning again the feed is started as regularly. Next, if to measure the gastric acid, if there is any problem with the patient is having any symptoms like abdominal bloating, fullness, then we take the aspirate from the tube, that is the gastric aspirate. Then we measure the acid content in the aspirate. If the most common side effects are the tube blockage, so this tube blockage can be dealt by flushing the tube with saline, or using chymotrypsin, which dissolves the solid block, or and guide wires can be used to remove the block. Then these tubes can be used when there is a requirement of nutrition support for up to 1 week. Next, the next is the gastrostomy. Gastrostomy is the placement of tube into the stomach directly through the abdominal wall. So this insertion can be done by two ways. One is the endoscopic, percutaneous endoscopic gastrostomy, and or transoral or push through technique. So endoscopic, percutaneous endoscopic gastrostomy is where the endoscope is passed from the nose into the stomach, and air is insufflated, gas is insufflated in the stomach, and abdominal wall. In the abdominal wall, stab incision is given and the tube is directly placed into the stomach with the help of a guide wire. But in case of oral or transoral or push through technique, the tube is passed, the guide wire is passed from the mouth. Orally, the guide wire is passed, then from the stomach, the incision is, the tube is pulled outside. So these are the two ways of insertion of a gastrostomy tube. And then this percutaneous endoscopic gastrostomy, this can be used up to feeding for up to 4 to 6 weeks. Up to 4 to 6 weeks. Next is jejunostomy. Jejunostomy, where this is preferred where the patient is having pancreatitis, most common in case of pancreatitis, or there is any outlet obstruction, gastric outlet obstruction. Jejunostomy is used. So this is done by inserting a tube, that is the Ryle tube usually used, which is passed into the jejunum by making a stab incision over the jejunum. The tube is passed and it is fixed to the abdominal wall. So regular feeds per hour are every hour are given through this jejunostomy tubes. And most common side effects are the tube displacement, leakage in the area of the placement of tube, and rarer side effect is the peritonitis. Then most common other side effects are the diarrhea, bloating. There is a picture showing the insertion of a beyond the nasojejunal tube. The tubes contain a radio opaque lining, so we can take a post-op X-rays to confirm the position. And this is a PEG tube, percutaneous endoscopic gastrostomy tube, which is placed in the stomach. Next, what are the complications of the enteral nutrition? Most common are the tube related, that is malposition, displacement, blockage, leakage, breakage, and local complications of the skin, erosion of the skin or mucosa. Next, gastrointestinal, diarrhea, bloating, nausea, vomiting, abdominal cramps, aspiration, constipation, and electrolyte disorders, vitamin and mineral and trace element deficiencies, drug interactions. Infective complications are the exogenous from the contamination of the food or endogenous through the patient. Next, coming to these are all the modes of enteral nutrition. Next, coming to the parenteral nutrition. Parenteral nutrition, in which all the provision of all the nutrition requirements through the intravenous mode. So most frequent indications are the in case of massive resections of the bowel or intestinal fistulas. Intestinal fistulas and the massive resections of the bowel. These two are the most common indications of parenteral nutrition. So the main there are two modes, that is peripheral parenteral nutrition and central parenteral nutrition. So whenever there is a when a cannula is inserted, so due to the insertion of the cannula, there will be endothelial damage, there will be venoconstriction, and whenever the drug or infusion is administered, there will be further venoconstriction. So inflammatory and vasoactive mediators are released, there will be inflammation, thrombosis, vein occlusion, there will be pain, and so these are the cycles of peripheral venous thrombophlebitis. So whenever we put a peripheral cannula, because there will be higher incidence of thrombophlebitis when we give this parenteral nutrition to the peripheral cannula. So most commonly the central lines like the subclavian or the external jugular or internal jugular lines are preferred due to the risk of thrombophlebitis. But there is one more entity called the peripheral inserted venous catheter, peripheral inserted central venous catheter, in which a catheter is introduced from the peripheral line, such as the cephalic vein. Then it is gradually reinforced into the central line. So the main point of entry will be the central line, but it is inserted at a peripheral level. So this is due to reduce the complication, but it also has a side effects of thrombophlebitis. But peripheral parenteral nutrition, peripheral inserted central parental nutrition can be used only for a period of up to 2 weeks. Next, the there is a total parental nutrition, in which here in the picture it is showing a central line inserted into the subclavian vein, which is below which is at the clavicular level. This the advantages of this line is that the patient can have her neck movements, whereas in case of external jugular or internal jugular line, there will be the problem of neck movements for the patient. So that line is placed in the neck, but in case of subclavian, it is placed below the clavicle, so there will be no problem of the neck movements. And this consists of multiple ports, but one port has to be used exclusively for the supplementation of fluids. Blood samples or the other fluid infusions should not be given through that port. And post insertion of the central line, an X-ray should be taken. It's mandatory to rule out the possibility of a pneumothorax, which is most commonly due to the injury to the pleura in case of during placement of a central line. So post procedure chest X-ray is essential. So after placing the central line, we calculate what are the nutritional requirements for the patient, then we administer the nutrients. Next, coming to the complications of parenteral nutrition. Complications related to nutrient deficiency, such as hypoglycemia, hypocalcemia, hypophosphatemia, hypomagnesemia. So all these together are called the refeeding syndrome. Because a chronically malnourished patient, we are giving feeding. If we give overfeeding, then there is a chances of developing refeeding syndrome. It causes arrhythmias, myocardial infarction. It altered myocardial function, arrhythmias, respiratory dysfunction, liver dysfunction. So treatment is proper calculation and giving of the nutrients which are required, and the nutrient requirements should be given slowly, not all of a sudden. All should be pushed to the body. So very given slowly. Vitamins are administered regularly. Next, chronic deficiency syndrome, such as essential fatty acid deficiencies of zinc, mineral and trace elements related to overfeeding. If there is excess glucose, there will be hyperglycemia, hyperosmolar dehydration, hepatic steatosis, hypercapnia, increased sympathetic activity, fluid retention. And if there is excess fat, hypercholesterolemia, formation of lipoprotein X, hypertriglyceridemia, hypersensitivity reactions. If there is excess amino acids, hyperchloremic metabolic acidosis, hypercalcemia, amino acidemia and uremia. Related sepsis, there will be catheter-related sepsis and possibly increased predisposition to cysts. So this is the important. There will be 3 to 11% of catheter-related sepsis in case of central with the use of central line. So this has to be identified. So we take the blood samples from the central line and from the peripheral blood. And if there is a similar organism identified in both the cases, then it is confirmed as a catheter-related sepsis. So the central line has to be removed, and based on the sensitivity, antibiotics have to be started to the patient. This is the most common and dreadful complication, the catheter-related sepsis. Next, related to line insertion, on insertion we have damage to the adjacent arteries, air embolism, thoracic duct damage, cardiac perforation, tamponade, pleural effusion, hydromediastinum, pneumothorax. But with long-term use of central lines, we have occlusion and venous thrombosis. The vein gets thrombosed and there will be venous occlusion. So this is all about the different methods of nutrition, electrolyte imbalance. Okay. Thank you.